Subscribe now and press the bell icon. Never miss an update.
Organizing Secretary RUFCONn 2022 for the
Perineal fascia is cut with scissors at the point it joins the psoas muscle as and when possible. The mass was densely adherent to the muscle all along its course and was slowly dissected using monopolar scissors and cautery, layer by layer, trying to find if there is an additional feeding vessel to the mass. As we were dissecting further and cutting through the dense adhesion, one of the feeding vessels, the mass completely, multiple feeding vessels on the inferior medial aspect brain was placed. The specimen was retrieved from the midline. The total console time was 44 minutes. The blood loss was 150 cc. Patient's post-operative course was uneventful. Brain both were normal. In our experience of over 9 years, we have operated 18 cases of post-chemotherapy robotic RPLND with mean operative time of 248 minutes and blood loss of 165 ml. The mean lymph node dissected was 16 and the survival rate is 100% up till now. 3 patients showed recurrence, of which 2 patients underwent surgery and 1 underwent chemotherapy. The case we present was one of the cases of recurrence among these patients. Thank you for your patient listening.
Complete the RPLND because you have already done it.
Yeah, we've already done this before.
Yeah.
That is why we did not complete it. So we've done a PET CT, which was
Just come out with the tumorectomy. You have to complete the RPLND.
yes, sir.
So that's make the proper RPLND. Okay.
Yes, sir.
Thank you, Doctor. From ICG installation on the foot to surface marking and foot placement to removal of lymph node at the lateral aspect of the patient in a split leg position. Now, targeting is done in the middle of the surgical field and other arms being docked. And then dissection starts with incising deep fascia lata and lifting up the lymph node packet, and all the boundaries are defined. Great saphenous vein was dissected meticulously and spared robotic pelvic lymph node dissection, and similar procedure was done on the right side. Our surgical console
My clock. Okay, can you hear me?
Yes, sir. Please go ahead.
All right. So, in a previous section, we have heard lots about partial nephrectomy, and I would like to share some of the results. I'll just take out my picture. The incidence of the renal cancer is increasing, and it has been recorded all over the time from 2014 onwards, and it is because of the rapid adoption of the cross-section abdominal imaging. And the data from the National Cancer Database demonstrated that the stage where one renal cell carcinoma increased from approximately 43 to 57% of a newly diagnosed between 93 and 92 in Shrenik's, one of the Shrenik's workshop, and that's how we started, and we learned from these 2 glands. It was a paper which was a landmark paper where he endocrinologist did a long-term follow-up after a partial nephrectomy at the 10-year follow-up, and a cancer-specific survival was 88.2% at 5 years, 73% at 10 years, and local recurrence-free rate was 94 to 92%. So we'd like to, the robotic partial nephrectomy, we'd like to share about data of 328 from 2010 when we acquired the robot till now. Now, opens radical nephrectomy, we need a partial nephrectomy. But if you see, the radical nephrectomy we have done maximum lap, while here we have done maximum robot. Robot has an age over the lap in doing a partial nephrectomy, at least in our experience. And this the mobility of the robotic arms were so beautiful that to dissect in a different angle and then suture it and close it is very nice. Of course, the Velox suture has made lots of difference, and the two-layer technique has been very, very important. I will go a little faster because I think we are behind time. Here the warm ischemic time was 16 minutes. Blood creatinine actually dropped. What happens very often, the patient comes down. Here the blood loss was minimum, and if you see the eGFR at the end of the 6 days before where you have a team like Samni, Sarvin, Abhishek, and this is a combined experience. Every complication.
હું ડૉક્ટર રવિન્દ્ર સબનીસ અહીંયા યુરોલોજી વિભાગના પ્રમુખ છું અને અત્યારે હાલમાં યુરોલોજી સોસાયટી ઓફ ઇન્ડિયાના પ્રેસિડેન્ટ છું. મારી જોડે ડૉક્ટર રસ્તોગી છે, એ અમારા મુરજીભાઈ પટેલ યુરોલોજી હોસ્પિટલના મેડિકલ ડાયરેક્ટર છે. આજે અમે અહીંયા ભેગા થયા છે. આ રૂફકોન એક સ્પેશિયલ કોન્ફરન્સ અરેન્જ થઈ રહ્યું છે અહીંયા. આ 3 દિવસની કોન્ફરન્સ અહીંયા મુરજીભાઈ પટેલ યુરોલોજી હોસ્પિટલના આયોજિત થઈ ગઈ છે, જેમાં કે દરે દેશમાંથી જુદા જુદા જગ્યાથી લગભગ 150 ડેલિગેટ અહીંયા આવી ગયા છે. અને આ 3 દિવસ ચર્ચા થશે જુદા જુદા વિષયમાં. કિડનીનું કેન્સર, પ્રોસ્ટેટનું કેન્સર, ટ્રાન્સપ્લાન્ટેશન, જુદા જુદા વિષયો પર ચર્ચા થશે. એક્સપિરિયન્સનું આદાન પ્રદાન થશે અને એ બાબત બધું ચર્ચા કરીને પેશન્ટને કેવી રીતે, દર્દીને કેવી રીતે લાભ મળે, દર્દીનું જુદા જુદા ઓપરેશનથી રિકવરી કેવી રીતે ફાસ્ટ થાય, કેવી રીતે સક્સેસ મળે, આ બધા બાબતો પર ચર્ચા થવાની છે. આ મુરજીભાઈ પટેલ હોસ્પિટલમાં ફર્સ્ટ ટાઈમ અમે રોબોટિક યુરોલોજી કોન્ફરન્સ આયોજિત કરી રહ્યા છે. એટલે અમને ખૂબ ખૂબ આનંદ થાય છે કે દરેક જગ્યાથી આટલા બધા લોકો આવ્યા છે અને અહીંયા હોસ્પિટલમાં આ કોન્ફરન્સ આયોજિત થઈ રહી છે.